Welcome to our live event, The Measles Comeback, What Every Clinician Needs to Know. My name is Kim Montanarello from Visual DX. Thank you for taking the time to join us for this important and timely conversation. We're thrilled to be joined by pediatric infectious disease expert, Dr. Zachary Most. Dr. Most is an assistant professor in the Department of Pediatrics at UT Southwestern Medical Center and is the associate medical director of infection prevention and control at Children's Health Dallas. Today, Dr. Most will share insights, visuals, and practical strategies that you can take back to your organization. Before we dive in, just a few housekeeping notes. This webinar is being recorded and will be shared with all the registrants, and we will be saving time at the end for questions. So please submit yours through the Q&A feature. So without further ado, let's get started. Dr. Most, the floor is yours.
Thank you very much for the introduction, Kim. Really appreciate it. Thank you all for taking the time to join this webinar today. I think this is a very important topic, a very timely topic, and I'm hopeful that by the end of the webinar today, everyone's going to feel more comfortable being able to identify and manage measles. Here are the terms of use, and I have no conflicts of interest to disclose. The objectives of today's webinar are to describe the method of transmission of measles virus and how to prevent infection, to review the clinical presentation of measles and how to diagnose infection, and to review methods to prevent measles infection in healthcare settings. So first, we're going to look at the epidemiology of measles. Measles is a highly contagious respiratory virus. A sick person with measles, often through coughing, will produce tiny infectious droplet nuclei that contain small particles that contain infectious measles virus. These particles are so small they don't even get carried to the ground with gravity and instead remain suspended in the air. They will then have the capability of filling the volume of the room that they are in and can remain suspended in air for up to 2 hours. So any person who shares airspace with somebody with measles is at risk of being exposed, and that includes up to 2 hours after the infectious person has left the room that they were in. This is what makes measles so contagious. Measles has a much longer incubation period than most other respiratory infections. After infection, there's typically a 10 to 14-day incubation period, although it can be extended as long as 21 days. Following that, the symptomatic phase of the disease starts, which we'll cover in more detail later. People with measles are infectious, meaning they can transmit infection to others, typically from 4 days before the onset of rash until 4 days after the onset rash. This is another thing that makes measles very tricky, is that most people are contagious several days before they have the rash to make it identifiable that they have measles. A couple of ways of measuring how contagious measles is. The attack rate of measles is 90%. This means that for people that are susceptible to measles, if they're in the same room and have an exposure to measles, 90% of them will contract the infection. Another way of measuring this is the basic reproductive number, or not. This is the average number of secondary infections after one infectious case in a hypothetical population where everybody was susceptible. This number varies based on the individual environment and specific settings. However, in most areas, it's estimated to be between like 12 to 18, which is one of the highest numbers for any virus that we know of. Measles around the world is a bit different than what we have experienced with measles in the United States. And it's important to put the experience we're having with the United States in the greater context of what's going on in the world. This image shows data from WHO, and this was the number of measles cases per country in 2000. And then fast forward to what it looks like in 2018. And it's important to note that there are some areas of the world that have attained measles elimination status, mainly most places in the Americas and Western Europe. However, much of the world is still dealing with endemic measles and continued large outbreaks of measles. Most notably, these are occurring in sub-Saharan Africa, Eastern Europe, and areas of the former Soviet Union. In fact, in 2023, it is estimated that there were 107,000 deaths around the world that are attributable to measles. This is a similar number to something like RSV. And most of these deaths have occurred in Africa. One death in 2023 in the entire region of the Americas, meaning North and South America, a number that we've already tripled in the United States alone in 2025. Looking now at measles in the United States and our history, prior to the licensure of the vaccine in 1963, measles was an incredibly common infection. Every person in the United States got measles during childhood. It was estimated that there were 3 to 4 million cases per year. There were 48,000 hospitalizations, around 1,000 encephalitis cases, and 400 to 500 deaths. You'll notice in this graph here that shows cases over time that there was a dramatic and sharp decline in measles cases that started around the mid-1960s. And it's really not a mystery as to why. This was when the live attenuated measles vaccine was licensed and started to be used. For the next 20 to 30 years, you can see that measles cases were dramatically reduced, although measles was still present in the United States. Then in 1989, a second measles dose was recommended. A second MMR vaccine dose was recommended as part of the routine vaccination series. And this got the population level immunity above the herd immunity threshold. And eventually, 11 years later, in the year 2000, measles was declared eliminated from the United States. It is important to note that elimination doesn't mean that there are 0 cases. It just means that there's no endemic transmission occurring person to person within the United States for 12 consecutive months. Now, if we zoom in on the post-elimination era, looking at the number of cases per year in the United States, here we can see just a dramatically different scale of infections compared to what was going on before. And in fact, I'm going to go back a slide and look at the y-axis on this slide goes up to 600,000 cases per year. Well, now in the post-elimination era, the y-axis only goes up to 1,400 cases. But there have been measles infections in the United States throughout this time. Most of these are in people who traveled to measles endemic areas and then returned, and occasional small clusters of infection in the United States that occurred, from those index patients who traveled. There have been a couple of notable larger outbreaks since elimination. In 2014, there was a large outbreak that was associated with exposures at Disneyland. And in 2019, there was a large outbreak that occurred mostly in New York. Note that this slide is already out of date for 2025. There are already over 800 cases reported in the United States in 2025, and the numbers keep increasing every week. Prevention of measles is really not that complicated of a topic. We know very well how to prevent measles more effectively than we do for most illnesses. MMR vaccine is extremely effective and really the only effective way to prevent measles. There's a routine vaccination series with 1 dose given at 12 to 15 months old. This leads about 93% of recipients to immunity. And a second dose given at 4 to 6 years old, which when combined with the first dose leaves about 97% of recipients immune. The second dose is not a booster. Its intent is really to capture those who did not respond to the first dose. When people do respond to measles vaccine, most of them will have permanent lifelong immunity. As studies that have been done that have followed up measles immunity, either through looking at serology or susceptibility to infection, even a long time after the vaccine, it continue to show that people remain immune. So it's hard to put an exact estimate on whether there's any sense of waning that maybe could occur over many decades, but there's been no evidence of that in long-term follow-up studies. A third dose of measles vaccine isn't really recommended in any circumstances unless the one caveat, which I'll cover right now. You can give measles or MMR vaccine as young as 6 months old, although it's not routinely recommended down to this age because it's not as effective because of circulating maternal antibodies to measles that inactivate the vaccine. But this can be given in high-risk settings like prior international travel and during outbreaks. But this dose does not count towards the routine series. So if somebody gets a vaccine between 6 and 12 months old, they're going to need 2 more vaccine doses later on. And for people above a year old, you can give their second MMR dose as early as 28 days after the first dose. And in some outbreak settings, this accelerated second dose of MMR is recommended. Contraindications to the MMR vaccine are only allergy, severe immunocompromise, and pregnancy. Although household contacts of immunocompromised or pregnant people can and should get vaccinated. Vaccine hesitancy is a really important topic, and I'm not going to really cover it much today. It's a bit beyond the scope of this webinar, but I would refer you to a resource from the AAP Red Book, which has a chapter on evidence-based communication strategies to increase uptake of childhood vaccines. Herd immunity threshold is a term you're probably hearing a lot in the lay media, medical circles. This is really a term that's meant to be used in vaccination campaigns with to set a target for vaccination levels in order to prevent any endemic transmission and outbreaks. And the herd immunity threshold depends on how contagious the disease is. And in fact, you can use this formula where you compare the R naught, or the basic reproductive number, to be able to calculate what the herd immunity threshold is. But the key here to note is that the more contagious the disease is, the higher the vaccination level needs to be in order to prevent outbreaks. And because measles has this very high basic reproductive number, it requires a really high vaccine uptake level in order to prevent outbreaks. And so when vaccination levels start to decline, we predictably would see measles come back as the first vaccine preventable disease, which then subsequently could be followed by other vaccine preventable diseases if vaccination rates continue to decline. And in fact, unfortunately, vaccination rates have declined pretty substantially in this country. So this data comes from the CDC that shows MMR vaccine uptake at kindergarten entry per state in the United States. And this is data from 2013-14. In this figure, blue states are good, that are meeting the target threshold of 95% or more of kindergartners having received measles vaccine. But then if we fast forward 10 years, there's a lot less blue on this chart. And in fact, very few states now actually have are meeting the goal threshold of 95%. This has made many different pockets of the country more susceptible to measles outbreaks, and has led to the current outbreak that we're seeing now. So 2025, there have been several measles outbreaks occurring all over the country. I'm not going to cover any of them in too much detail here, because anything I say will be out of date very quickly. And I reference you to check out the CDC website, which keeps track of the ongoing current measles outbreaks. The largest, most notable one started in the South Plains region in West Texas, and has spread to neighboring states like New Mexico and Oklahoma, as well as Mexico, and other states are experiencing outbreaks as well, like Ohio and Indiana and Michigan. So now that measles is here, and we're in the measles comeback, it's important for people to be able to recognize and diagnose measles. Most clinicians in the United States today, having trained and practiced during the elimination era, have likely never seen a patient with measles. And so I'm hopeful that what we cover today will make everyone more confident in being able to recognize a case of measles. And I'm going to also highlight some of the resources with Visual DX, because measles is a disease that really is diagnosed based on how it looks, and using your visual inspection. And images can be a very useful resource when trying to interpret a patient's rash. The key factors in recognizing someone with measles are to use your normal history and physical examination skills. And the things you want to focus on are the signs and symptoms of the patient, their exposures, and their immunity. For signs and symptoms, and we're going to cover these in more detail coming up, the things you want to ask about are whether they've had fever, cough, coryza, conjunctivitis, and rash, Koplik spots. And you want to get a good sense of the timing of the symptom onset, because measles follows a predictable symptom timing, and the quality of the rash, whether there's vesicular lesions, whether it's raised or flat and such. Even in the midst of outbreaks going around the country, we still are in a measles elimination country. And so you want to make sure a patient has a plausible exposure to measles if you're going to consider it as a diagnosis. This could include travel to an endemic area, travel to or living in an outbreak area, or any known exposures, or to somebody who has measles or is suspected to have measles. And susceptibility, noting that most people, the vast majority of people who are up to date with vaccination, as well as those who have had a history of measles, will have permanent lifelong immunity to measles and will be much less likely to have infection. This figure shows over time the progression of symptoms of measles. And in most people with measles, this is a very well-defined time pattern. The relationship between the different times when symptoms come on is pretty consistent and predictable in measles. So following a 10 to 12-day incubation period, patients will usually develop fever and URI symptoms in what's called the prodromal phase, for the next 4 days. And then around day 4, we'll develop the more classic measles rash. And then it will be in their rash phase for the next 3 or 4 days, and then the symptoms will convalesce. And so now we're going to cover each of these phases in a little bit more detail. The prodromal phase of measles resembles an upper respiratory infection and can look very similar to any other viral respiratory infection like RSV and influenza. And so it can be very difficult to diagnose measles at this point in the illness. Typically, patients will start with fever and then which will get progressively higher over the next several days. They'll have URI symptoms like a prominent cough, profuse rhinorrhea, which can lead to inflammation of the nasal mucosa called coryza, and prominent conjunctivitis that might not show up much until later in the prodromal phase, but is usually quite obvious later on. Patients with these symptoms classically look and feel pretty ill. They're not usually bouncing off the walls and smiling and looking happy like somebody with like roseola. People with measles typically look pretty ill. And during the prodromal phase, often late in the phase, patients can develop the pathognomonic enanthema, which are called Koplik spots for measles, which we'll go over on the next couple of slides. These are well-defined. They're usually erythematous spots that are white or blue in the center. Although sometimes, depending on the area, the white or the blue spot isn't as prominent. And they're not petechial, so it shouldn't look like the petechial lesions of strep throat, and they're not exudative as well. Here's an example of Koplik spots on the hard palate of somebody with measles. And here you can see the well-defined erythematous lesions here. On the palate, often the lesions are not necessarily showing any like white or bluish discoloration as obviously. And so sometimes it's just this erythema. Here's an example of them on the buccal mucosa, which is where they're most commonly found on exam. And here you get the central whitish, some people describe it as white or blue or gray, but a light color in the center. And some of these photographs, it is a little bit harder to tell in the photograph than it would be in person. But if you look closely at this image, you can see a faint red or erythematous sort of halo around most of these lesions, especially the larger ones. And so that's what classically defines these as being Koplik spots. Then patients with measles will enter their rash phase. The rash usually appears about 14 days after they were exposed and about 3 to 5 days after the prodrome begins. It begins as flat or macular erythematous spots on the face, often all the way at the hairline or the scalp, and then spreads cephalocaudally downwards to the neck, to the trunk, and the extremities, including eventually the palms and soles. Some patients, though, with severe immunocompromise may not develop the rash. Even though the rash is mostly macular, it can be maculopapular as well with some small raised red bumps. And the spots may start to coalesce as the rash spreads into larger erythematous areas. Usually the fever spikes quite high right around the time the rash starts, and the fever can get as high as 104 or 105 Fahrenheit. And then the fever and rash subside over the next several days. On the next few slides, we're going to look at some examples of the measles rash. And these are all images that come from Visual DX. Here is a measles rash on the extremity of a patient. It shows here this diffuse macular and somewhat maculopapular rash, and you can start to see some of these erythematous areas are starting to coalesce as well into larger red splotches. Here is a rash on a patient's chest and upper extremity. And again, you can see really diffuse erythematous macular lesions that are coalescing into larger splotchy lesions. This is a measles rash on the patient's back. This one is more predominantly maculopapular with a lot of raised lesions on the back here. Here's a picture of a measles rash on a patient's forehead. And this is really notable because quite often this is around the time patients are presenting for care is early when this rash has first started spreading. And the rash may be most prominent on the forehead or the scalp or hairline area. And you can see again here this diffuse macular rash, somewhat maculopapular rash in this image as well. Here's a very classic looking measles rash on the extremity of a patient. And again, you can see at the top of this image, some of these lesions have started to coalesce into larger lesions. Here's another classic measles rash image. And I like this one a lot because it covers both you can see the face, the torso, and the extremities all really severely involved with this rash. It's really everywhere. In particular, quite a significant involvement of the face. And also highlighting what I mentioned before, that people with measles usually look pretty ill. You can get the impression, just from this photograph, that this child does not feel well. And you can also make out a little bit of nasal discharge with some signs of coryza in this image, and a lot of redness around the eyes that could suggest maybe the patient's rubbing their eyes and could go along with conjunctivitis. Obviously, we don't see the conjunctiva in this image, but this image does really capture very well the symptom complex of measles. People that have been diagnosing measles a lot during the current outbreak have been able to say that usually they can diagnose measles from across the room. It's also important to note that a lot of the descriptions, of the classic descriptions of the measles rash, do have a bias towards people of Western European backgrounds with lighter skin. Rashes often look very different than the classic descriptions in people of color and people with darker skin. One of the great things about the Visual DX as a resource is that you can also find images of these rashes in people of color and can specifically search for it. So here's a lesion, an example of measles rash on a child with darker skin tone. And one of the things that's noticeable is that the rash sometimes is not quite as erythematous. It's not necessarily as red. It can sometimes be more of a darker, almost looking like a hyperpigmented kind of lesion, but does have really the same distribution of involvement. Here's a measles rash up on the hairline and the face of a child with measles. And here's another example of a measles rash on the face and upper torso of a child with measles. And again, here you can still see in this case that there is erythema involved. And again, it's still a diffuse maculopapular rash, is going to really not spare any area of the body. So after the rash starts to subside, patients can enter a convalescent phase. Classically, there's a description of the rash fading from red to copper to brown, and it fades in the same pattern at which it appeared, cephalocaudally. And so if you do see somebody in this phase, they might not have much rash at all on their face or their torso, and maybe it's just on the extremities at this point. And as the rash resolves, a fine desquamation can occur, but it doesn't typically lead to any permanent scarring. So that's the classic presentation of measles, and it is important to be aware of some alternate presentations of measles. The term modified measles is often used to describe a non-classic appearance of measles, where the symptoms are often more mild, but maybe more prolonged and can last up to 20 days. And this occurs in patients that have partial immunity to measles. That could be an infant who's less than 9 months old, who has maternal antibodies, at least to some extent. A previously vaccinated person who had vaccine failure, which, even though it's rare, does occur, or somebody who was exposed to measles and received immune globulin for post-exposure prophylaxis. It is important to note this. A study was recently published from the CDC, their measles surveillance group, who showed that during the post-elimination phase of measles in the United States, these kinds of modified measles presentations were substantially more common and accounted for nearly a third of cases of measles. And so in the person who may have some background of immunity to measles, but was exposed to measles and is having symptoms that maybe don't meet the classic description, but have some of these alternate modified features, you still need to have a high index of suspicion for measles. And then the term atypical measles is intended to reference a very specific scenario, a atypical measles rash that starts on the extremities rather than at the face, has a more yellowish hue, and is associated with more systemic symptoms. This was described to occur in patients who received a different measles vaccine, a kill virus measles vaccine that was on the market from 1963 to 68. This was, again, a pattern of symptoms that was seen in the 70s and the 80s. It should not be a very common, it should be an extremely rare presentation of measles today, as no one's received this vaccine in nearly 60 years now. There can be complications to measles infection. Higher risk groups for complication include young children and infants less than 5 years old, and people older than 20 years old. And at the extremes of age, the risk gets higher. Pregnant women with complications both to themselves and to the developing fetus. People who are immunocompromised, and people who are malnourished, especially those who have vitamin A deficiency. Secondary bacterial infections are common, including otitis media and diarrhea, and pneumonia, whether it's bacterial or from the measles virus itself. Encephalitis can occur. Some patients with measles have a presentation called hemorrhagic measles, which is a more severe measles infection that could resemble a DIC type picture. This is pretty rare though. And subacute sclerosing panencephalitis, this is a progressive long-term progressive encephalitis that can develop years after a measles infection, sometimes 6, 7, up to 10 years after a measles infection. And it is progressive and there's no treatment for it, and it uniformly leads to death. It's a rare complication of measles, but as cases start to rise, it is something that we might have to be on the lookout for going forward, even into the next decade. Previous reports on measles outbreaks have shown that the mortality rate for measles infections is about 1 to 2 per 1,000. Although again, this is higher in areas that have more higher risk of malnutrition. The CDC has this flow chart to guide clinicians in when they should be suspicious for measles and when they may consider testing a patient for measles. This flow chart is available on the CDC website and is intended to be used when you are not in the middle of an outbreak, when measles is not highly incident in the area that you're at. And I'll go through this pathway briefly here, and highlighting that it covers the same things that I mentioned earlier, that the keys to making this evaluation are signs and symptoms of measles, understanding whether there was an exposure, and the immune status of the patient in regards to measles. So first, you check whether the patient has fever, generalized maculopapular rash, and not vesicular lesions. And so if they are vesicular lesions, it could be something like chickenpox, but it is not measles. So if they don't have all three, measles is unlikely. If they do, then you look for whether there's any potential exposure, which could be international travel, especially to an area that's endemic for measles, any domestic travel to an area that might be a measles outbreak going on, or a known exposure. If you meet those criteria, you should suspect measles in that patient and go down that pathway. But if they haven't been exposed, you might still suspect measles if the symptoms are really consistent and they're in the right setting for exposure. So for somebody, at this point, you know that they've got the fever and the rash, but next you want to check to see if they had the really classic symptom complex of this prodrome of measles before they had their fever and their rash. And in this case, if even just one of these three, cough, runny nose, or conjunctivitis, can meet that. And if they do, well, if they've had their MMR vaccine in the last 21 days, be aware that the MMR vaccine itself can cause a reaction that leads to a measles-like rash. People who have that reaction are not contagious. They can't spread the disease to anyone. It's very mild and it goes away very quickly, but it could look a lot like measles. And so you want to try to avoid testing people in that group. And so if it does fit well with people who had the measles vaccine, then it's likely a reaction to that. And then you check whether they are immune to measles or not. And if they're not immune to measles and they've met this sort of symptom complex, you should also then suspect measles and go down that pathway. Whereas if they are immune to measles, measles is uncommon. So you are less likely to want to test that patient. Although again, you have to consider consider how specific the scenario is, especially including this concept of modified measles presentations. Measles nowadays is typically diagnosed using a PCR test. The ideal swab is a throat swab or a posterior pharyngeal swab. You can use a nasopharyngeal swab as well. And you would use a polyester fiber tip swab, which is usually Dacron or nylon with viral transport media. This is the same kinds of equipment you would use to do a PCR test for other respiratory viruses like COVID-19, influenza, and RSV. You can also send PCRs from urine and blood. I wouldn't recommend routinely doing that, but if you're considering it, you may want to talk with an infectious disease specialist. You can also use serology to help in the diagnosis of measles. A positive IgM often indicates an acute infection, although it can sometimes be false positive. A positive IgG in the acute phase typically indicates immunity to measles. But if it is low, you can then also check convalescent titers in 2 to 4 weeks. And if there's a 4-fold rise in IgG later on, that is pretty specific to diagnose measles, but that doesn't diagnose it in the immediate acute phase. You'd only be able to diagnose it later. The hallmark of management of measles is supportive care. There's no proven antiviral therapy that's been shown to be effective in measles. Vitamin A is recommended by the WHO for all patients with measles, and this is based on observations that vitamin A deficiency is common in measles and associated with worse outcomes, and studies that have shown in developing countries that supplementing patients with vitamin A does reduce severe complications of measles. In the United States, where nutritional deficiencies and vitamin A deficiency is much less common, it's really unclear exactly what the role is for vitamin A. So at the very least, I think most experts would recommend using a vitamin A supplementation for all patients with severe enough disease to be hospitalized, and for anyone who has suspected vitamin A deficiency or nutritional deficiency. And you can consider it for those that are being treated as outpatients with measles. But all of this needs to be done under the supervision of a physician, as overdoses of vitamin A can lead to toxicity. Vitamin A does not prevent the transmission or acquisition of measles. And there's no alternative therapies that have proven to improve outcomes in patients with measles, and this includes corticosteroids and macrolide antibiotics. So we've talked a lot about what does it mean to be immune to measles and kind of glossed over it until now. So the CDC has a definition for what evidence of immunity to measles means. This includes one of the following 4 criteria: documentation of age-appropriate vaccination with a live measles vaccine, laboratory evidence of immunity, which is a positive IgG, laboratory confirmation of prior infection, or anyone born before 1957 because of how common measles was back then. For healthcare personnel, at least at our hospital, we do require one of the first 3 criteria. We don't accept just being born prior to 1957, and that's a common thing in a hospital setting. The caveat here is that severely immunocompromised individuals may not be considered immune to measles, regardless of their vaccination status. They may lose their immunity because of their immune suppression. So it's very specific to what immunocompromising condition or medication you're on. And so if you have any concerns about yourself, whether you might fall under this category or not, please consult with your physician. I will also say that I don't routinely recommend checking everyone's anti-measles IgG titers, again, because of the listed criteria here. So if you're known to be fully up to date with vaccination, you should just presume to be measles immune. And in fact, checking titers can be misleading because a positive IgG indicates immunity. A negative IgG doesn't exclude the possibility of immunity. There's other aspects of cellular immunity, and there's memory antibody responses that can still occur. So it can be a little bit misleading to be checking IgG titers, so I don't routinely recommend that in most circumstances. People who have measles should isolate at home until 4 days after their rash first appears, when they're no longer contagious. If you are exposed to measles and you're not immune, you should be excluded from school and childcare settings for 21 days. If you're hospitalized, you should be on airborne precautions. And if you work as a healthcare personnel, you should be excluded from work from day 5 through day 21. Although if you're an exposed immune individual, you do not need to quarantine, although you should monitor for symptoms for up to 21 days after exposure. And for people who are exposed to measles, because of the long incubation period, there is a window in which you can give post-exposure prophylaxis. For people who are immune to measles, though, we don't recommend post-exposure prophylaxis in any setting. You've already gotten your prophylaxis. For people who are not immune, if they have no contraindications to MMR vaccine, they can get MMR vaccine up to 72 hours after the exposure. Otherwise, they can get immune globulin up to 6 days after the exposure. And this includes people who are severely immunocompromised and who are pregnant and in infants. So now that we may be seeing patients with measles more routinely, or at least at an increased rate compared to the past, it's important to understand, given the very contagious nature of this disease, how do we protect healthcare personnel and other people in healthcare settings? The CDC and NIOSH more globally refer to what they call the hierarchy of controls, where they the order in which they're showing these different steps here is intended. It's showing the most effective measures at the top and the least effective measures at the bottom, right? And so thinking about something like measles, elimination. If we could eliminate measles from the United States, that would be the most effective way to prevent anyone from getting measles in a healthcare setting. Whereas the things that we think about perhaps the most, like do I have N95 respirators and are the right PPE, is actually the least effective of all of the interventions that we do in preventing the disease. It's still important, but it goes to show that there's a lot of other steps that can help to prevent the infection. So really the most important step is making sure that healthcare personnel are immune to measles. You want to require that all healthcare personnel document immunity to measles prior to their employment. And by immunity to measles, I mean the same criteria that we talked about on that prior slide. Those who have an exemption to measles vaccine or who are severely immunocompromised, they cannot see patients with measles. They should not be allowed to see patients with measles even with PPE. The next step is to be able to identify measles early enough so that somebody with contagious measles doesn't get into an environment where they can spread it to lots of people. In the healthcare setting, that's often like a waiting room. Think about like a busy ER waiting room. And so really the most effective way to do that would be screening for possible measles before patients arrive. This could be done via calling ahead or using some sort of electronic health record application for screening. Communicating with other facilities when people get transferred over, and thinking now about establishing a protocol of how you would safely bring somebody with suspected measles into your healthcare setting, perhaps using a back door or another entrance that doesn't involve going through a waiting room or a crowded hallway. And then the next layer of defense is screening upon arrival when patients get to your healthcare setting. And you should be asking patients about potential exposures to measles, travel to areas where there could have been risk for measles, and whether they have symptoms of measles. People that have a concern for suspected measles need to be isolated immediately once that concern is identified. You should provide that patient and any family members who are with them a medical face mask right away. That face mask is not going to completely eliminate the risk that they can transmit measles, but it can help to reduce how much infectious measles particles they're releasing into the air. You really want to get that patient out of any common areas right away, like for instance, if they're in the waiting room, and place them in a single patient room with a closed door. You want to use an airborne infection isolation room or a negative pressure room if one is available. But even if one is not available, get them out of common areas, get them in a room with a closed door as quickly as you can. The recommended isolation precautions then are to be on airborne and standard precautions. And as a review, airborne precautions means the patient should be placed in an airborne isolation room. All healthcare personnel must wear an N95 or equivalent respirator, even if they have documented immunity to measles. Consider transfer to another facility if no airborne isolation rooms are available, and you should discuss this with local health authorities prior to transfer. You maintain airborne precautions until 4 days after the rash first appeared, and you use standard cleaning and disinfection procedures on the room. Disinfection is important for measles, but it is susceptible to the normal disinfectants that would be used like ordinary amines, alcohol, or bleach. Additionally, you want to encourage respiratory hygiene and cough etiquette. It seems simple, but even simple things can go a long way. Have the patient wear a mask whenever they're not in an airborne isolation room with a closed door, and try to limit patient transfers as much as possible. For any healthcare personnel that get exposed to measles, if they are immune, they should not need any work restrictions, and it should just be recommended that they monitor themselves for symptoms for 21 days and quickly report if they develop any symptoms. However, if they're not immune to measles, first, you can administer post-exposure prophylaxis, and secondly, they should be work restricted from day 5 through day 21 after exposure. If healthcare personnel has known or suspected measles, then they should be work restricted until 4 days after the rash first appeared. Okay, so that was the review, and thinking forward, what happens next with measles? Where are we going, and how do we prepare ourselves for what's out there? In regards to the current outbreaks that are going on, it's really hard to tell exactly what's going to happen. It seems that these outbreaks are often finding pockets of communities that have lower vaccination rates and then maybe over time spreading from one pocket to another. Because the vaccination rates are still high enough in this country, we're not going to see a really gigantic, outbreak, like nothing like the number of cases we saw with COVID-19. But we can continue to see propagation and spread and finding new pockets of under-vaccinated communities, which could eventually lead to continued sporadic measles outbreaks, endemic transmission, and eventually the U.S. might lose its measles elimination status. If that's the case, then we have to be ready for measles to sort of just be with us and be in our differential going forward. So how do you prepare for a measles outbreak? These are the steps that we've been taking locally and that I'd recommend everyone start to work on, even if you're not seeing measles cases yet in your area of the country. This includes communication. You want to communicate with your healthcare providers. Similar to what we covered in this webinar today, most people are not going to be very familiar with measles symptoms. And so share what their signs and symptoms are of measles and what your local protocols are for handling patients with measles. And also communicating with the public. We've got to get the word out that vaccination is the best way to protect individuals from measles, and as a community to help us prevent outbreaks of measles in our community. We have to make sure we're protecting our healthcare personnel. So review your measles immunity requirements at your institution and ensure you have adequate supplies of PPE, in particular N95 respirators, as well as ensuring that your healthcare personnel are fit tested for those N95 respirators. Have a system in place to be able to screen for measles, and including asking screening questions to all patients about symptoms, exposures, and travel, and trying to arrange pre-arrival screening if possible. Get a sense of what isolation you have available to you, what available airborne isolation rooms there are, and create a plan for immediate isolation of a suspected case. Better to think of a plan ahead of time of where you're going to put this suspected patient rather than having to come up with something on the fly. And for testing, review what the testing recommendations are, determine if you have a safe space to do the testing, and make sure you have the supplies for testing and where you're going to send the testing. You might go to a public health lab. There are lots of commercial labs now that do measles PCR testing. So, come up with a plan, make sure you're talking with your lab on where the testing is going to go. So that's the end of the slides that I have for today's presentation. Thank you all again so much for your time and your attention covering this really important topic. I'm going to pass it back to Kim now, and we're going to go over additional questions that have come up.
Yeah, thank you so much, Dr. Most. Again, if you have questions, please put them in the Q&A. We do have some that we can go over now. Someone's looking to see if, with the CDC, is there any other reliable resources that help track infectious outbreaks that you could also recommend besides the CDC or as well as?
Yeah, that's a great question. Local health departments, either at the state or the county level, are really the ones with the boots on the ground who are doing the surveillance for these diseases and for these outbreaks, and are the ones who are really collecting the data on it. CDC mostly just compiles data that's given to them from state health departments. And so I know, being in Texas, I'm checking. Our state health department is doing updates on measles cases in the states twice a week. They're updating their websites. They're fantastic with the way that they're reporting the cases and showing the distribution of cases around the state, as well as some demographics of those who have it. So state health departments and their online resources are going to be very useful for tracking these diseases, as well as WHO does also provide a lot of data on measles. They don't update it quite as regularly, but that's another source for information on incidence of measles cases really all over the world.
A couple of things have come in about the use of vitamin A. I know you touched on this, but if you could explain a little bit more about how the advantages of using that for any patient age 12 months or older.
Yeah, so it's a complicated topic because we don't have a lot of good data in the United States that shows that vitamin A improves patient outcomes for patients with measles. And there's reason to suspect that a lot of the benefits that we're seeing from vitamin A in some other trials that were done in developing countries might not carry over to the US, where we don't have as high of rates of malnutrition. That being said, the best health authority on this in the world is the WHO, who recommends vitamin A supplementation for all patients with measles. And so balancing these two things, my usual recommendation is, if it's severe disease or if you suspect nutritional deficiencies, to go ahead and give vitamin A for patients with measles. And then you can consider it on a case-by-case basis for people with more mild disease who are being treated as an outpatient. But I think a lot of the confusion with when to give vitamin A or not really is because there's ambiguity. We don't really know what the benefit is in our population here in the United States.
There's a question about a measles PCR. They have a viral media in the office for checking HSV. Is there any use for that for a measles PCR?
I gotta say, off the top of my head, I don't know exactly what media is used for HSV PCRs. So I would double check. You can ask your lab or whoever your supplier is, and or you can just look at the packaging for what those for what that HSV PCR collection kit is. What you're looking for is a Dacron or nylon tipped swab in what's called viral transport media.
Great. And that's really the questions that have come in. I can wait a couple more minutes if anyone else has other questions. But in the meantime, I'd be remiss if I didn't say that Visual DX, you mentioned, is a great resource to looking up not just information about measles, but really any infectious disease, any disease that might appear on the skin, with information that you can provide to your patients and just helping you with management and treatment. So want to make sure that everyone knows about that. And I will put in the chat the link to our measles page right in Visual DX. And someone does have a question if the presentation will be emailed to you. We will be sending out the recording for everyone to have access to with all the great information. So with that, again, I want to thank Dr. Most for his time today. Really educational. Thank you so much for your expertise and insights. And thanks to all of you for attending today. Like I said, you'll receive the recording link and any additional resources we can help to find within Visual DX to support your clinical practice. And on that note, thank you so much and have a great rest of your day.